Hello everybody, welcome to my 2020 update on MRI for active surveillance. Here are my disclosures. At the very outset, we need to distinguish between active surveillance and watchful waiting. Active surveillance is a strategy that delays curative treatment for lower risk prostate cancer until it is warranted, and when treatment is undertaken, it is undertaken with a view to cure the patient. Watchful waiting forgoes curative therapy for prostate cancer of any risk, and interventions occur when symptoms are about to occur or are imminent. And the intention here is to palliate patients. So, what sort of patients are suitable for active surveillance? These, in general, tend to be low risk patients. So, Gleason 6, low volume disease, low PSA, and either invisible disease on imaging or just on one side of the gland. And as I said, in this particular instance, it is to avoid over-treatment. But we know there are other groups of patients with slightly higher volumes of disease or slightly higher PSAs, or maybe even Gleason 3+4 cancers where there's only a small component of Gleason 4 disease, where active surveillance can be tried. But in this case, it's usually to delay curative therapy. So the typical selection criteria are low PSA, low Gleason score, one side of the gland, a few cores involved by Gleason 3+3 disease, and the follow-up schedule in general is every 3 to 4 months having PSA and DREs for the first couple of years and then every 6 months, and having biopsies. Usually you'll have a biopsy within the first couple of years, and this is called the confirmatory biopsy, and then every 3 to 4 years until you are 80 years old. Well, there are a number of triggers that are used for active surveillance, triggers for intervention. These are increase in Gleason grade, an increase in the extent of disease, an increase in the core involvement, and a doubling time of less than 3 years. But more and more we see patients or physicians who then switch from active surveillance to active therapies. There are a number of challenges for active surveillance. Firstly, we know that the diagnostic process, which relies on PSA and systematic biopsies, contributes to poor risk assessments. We also know that optimal selection criteria are not fully agreed upon. But one of the other challenges is that a lot of patients get treatment over time, and a substantial number of these are due to histological reclassifications. And one generally finds that as time goes on, that there's a general intolerance to the AS procedures, which then contributes to discontinuation rates. So let's start off by looking at the current diagnostic process, which relies on PSA and systematic biopsy, and show how they contribute to poor risk assessments in potential AS patients. So if you look on the right-hand side, we've got pathological examinations of low-risk prostate cancer patients, and you can see that these patients went in and had prostatectomies for what was apparent low-risk disease. And at final pathology, you can see that the disease was only confined to the organ in 75% of cases. And if you look at the prevalence of Gleason 3 disease, remember they went in with Gleason grade group 1 disease, you can see that's between 20 and 25%. So there is a great deal of misclassification going on using PSA and systematic biopsies. Another challenge is the discontinuations that occur over time. So you can see this is a cohort of patients that has been followed over 10 years. And what you notice is that 10 years, about 70% have come off active surveillance. And this is because of either protocol-based discontinuations, and that's this green line here, or, and in the later stages, non-protocol-based discontinuations. So you can see how initially there's a drop-off, and that's due to this misclassification that we talked about. But then even after that stage, we continue to see patients dropping off because they become less and less tolerant of active surveillance. So we need a number of different biomarkers to address these challenges in active surveillance. We need diagnostic biomarkers to detect patients who are ineligible and not suitable for active surveillance. We need prognostic biomarkers that predict the future likelihood of tumor upgrading or AS discontinuations. We need predictive markers which will tell us which patients are more or less likely to have a favorable outcome to AS, and we need response biomarkers to monitor patients during AS for the outcomes that we want. MRI is certainly able to address some of these, and one of the things that MRI is able to do is to decrease the diagnosis of low risk disease and therefore the need for active surveillance. And in this particular instance, MRI is acting as a diagnostic biomarker. So here's a randomized study from Canada, a multi-center study. You can see that systematic biopsies were compared to MRI targeted biopsies alone in positive cases. And you can see how the prevalence of low risk disease is cut down from 22% to 10%. So we decrease the total number of patients requiring active surveillance. When we look at MRI scans in patients who are already on active surveillance, there's a number of features that we can look at that predict adverse pathology or poor outcome. So one of the things we can do is just measure the ADC. And you can see on the right-hand side is the treatment-free survival. And if you have a low ADC, you're more likely to come off active surveillance. You have a higher ADC, you're more likely to stay on ADC. And we looked at the value of the PIRAD scoring system in patients who were on active surveillance. And again, you can see that if you had PIRADS 1, 2, or 3, you were more likely to carry on active surveillance. But if you had PIRADS 4 and 5, you can see how you were likely to drop off being on active surveillance. So here's a typical man who would be suitable for active surveillance. 60-year-old man, low PSA, 5% of cause on the left-hand side, and he has a PIRADS 1 abnormality. This man stayed on active surveillance for about 8 years before he progressed. Here's another man who should be suitable for active surveillance. You can see bilateral Gleason 6 disease, but you can see anteriorly there's a focal abnormality, and this was targeted and we found a 9 mm core of Gleason 3+3 disease. So you can see how he was suitable for active surveillance, but when we did a targeted biopsy, he goes up and is no longer the classical patient. And this speaks to the risk inflation that occurs in patients who are going on to active surveillance. And we'll come back to this risk inflation issue later. Now, clearly, this man is not suitable for active surveillance, although if you were to just do PSA and DRE and biopsies, he would be suitable, but on MRI you can see he's clearly got T3B disease. Similarly, this man is not suitable for active surveillance, although conventionally he would be. So PSA is okay, the number of cores is okay. He never had a MRI at the beginning, but he's clearly got a T3 cancer at the left apex, so it doesn't carry on active surveillance. And in fact, this has been looked at by a systematic analysis in 2015, the presence of a positive MRI occurs in about 3/4 of men who are on active surveillance. And when they are positive, the reclassification rate is about 2 in 5. Another way of putting this is to say that if you don't see anything on MRI, then it's a very powerful feature for the absence of poor pathology. Now, one of the things I said was there are other patients who are also suitable for active surveillance, and these could include patients who have one other factor that is adverse. So, for example, a PSA of 10 to 20, or a slightly higher core involvement, or bilateral Gleason 3+3 disease. Now we know that these people actually do quite well. So if we looked at MRI with PSA being the only unfavorable feature, we know that the outcomes can be very comparable to low risk disease. So here's a typical example of somebody who has 3+3 disease, but you can see his PSA at the outset is 10 and 20. So this patient has no index lesion. He is suitable for active surveillance because he's only got one unfavorable feature, and that's his PSA. You can see how we follow him over time, and you can see that after 4 years, his PSA rises up to 24.9, and a rebiopsy at this stage shows risk migration. So you can see how he's gone from a Gleason 6 to a Gleason 7 cancers, and clearly he now needs treatment. Here's another patient, but this time with a little mass in the left peripheral zone. This man starts with a PSA less than 20, ends up with a PSA more than 20, and you can see the growth of the lesion in the left peripheral zone. So again, we can see how we can have these intermediate risk prostate cancer in whom we can postpone, at least for a while, the necessity for undertaking definitive therapy. So you should consider MRI and active surveillance for Gleason 6 disease when the PSA is between 10 and 20, or if they have a high PSA density, because you will then be able to say whether the patient should or should not be on active surveillance. There is another group of patients with intermediate risk prostate cancer who would in fact be suitable for an initial trial of active surveillance, and these are patients who have less than 10% of Gleason 4 disease. When you do prostatectomies on patients with Gleason 3+4 disease, the presence of a positive MRI predicts for a higher rate of adverse pathology, in other words, T3A or T3B disease. It also predicts for disease upgrading, in other words, Gleason score greater or equal to 3 or lymph node positivity. And in fact, this paper is one of a number of papers, all of which say that if you have intermediate risk prostate cancer with Gleason 3+4 disease, if you have an abnormality that's either a PIRATS 4 or a PIRATS 5 lesion, then you should not undergo active surveillance. So here's a man who had 3+4 disease on TURP chippings, but no focal lesion was visible within the prostate gland. And you can see that he then undergoes a confirmatory biopsy, which in fact shows Gleason 3+3 disease. And we then followed him over time, and he stayed stable over several years. So somebody who was 3+4 without anything visible is often suitable for active surveillance, but you need to follow them carefully. And this is completely consistent with this paper that was published recently, which evaluated the absence of a focal lesion on a prostatectomy and how these patients did over 15 years. So you can see how the absence of a focal lesion had a very good prostate cancer specific survival over a period of 15 years. So the absence of a focal lesion on MRI is coming through as a very strong predictor. So can we use MRI to reduce the need for confirmatory biopsies early on after starting active surveillance? We know that repeated biopsies, both the confirmatory as well as the surveillance biopsies, contributes to the declines in AS participation rates over the longer term. And we saw these declines in the participation rates over time. Remember, we said that we needed confirmatory biopsies in the first year to pick up on those patients that were misclassified. If we were to use MRI at the very outset, could we avoid that early confirmatory biopsies between year 1 and year 2? So here's a randomized study that showed that there were lower upgrading rates when used MRI at confirmatory biopsy. You can see 130 men roughly either had systematic biopsies or had MRI directed biopsies at confirmatory biopsy. And then when you looked at the next 2 years, you can see that the failure rate due to disease progression was much lower in the MRI group. So the AS failure rate or the disease progression rate in the MRI group following biopsy was 19%. But if you had performed a systematic biopsy at confirmatory biopsies, then you had a much greater failure rate. So MRI at confirmatory biopsy halves the number of patients failing AS subsequently over the next couple of years. So can we improve this even further? Well, it turns out you can use MRI and PSA density together to reduce the need for confirmatory biopsies. However, it does not appear that MRI is improving the long-term participation rates. So if you look at the graph on the right-hand side, where MRI was used for diagnosis and for follow-up, you can see over 5 years, almost 50% of men come off active surveillance. And many of these men come off without upgrading, but quite a few men come off active surveillance due to histological upgrading. And indeed, if you looked at MRI in patients who are already on active surveillance, you can see that over the next 3 years, 35% of patients stop AS. If you were to perform your first MRI in the first year of active surveillance, 30% of patients stop in the next 3 years. And even if you used MRI for diagnosis and for follow-up, 30% of men come off active surveillance. So it appears as though MRI is leading to more patients being considered unsuitable for active surveillance. And it could be that there is risk inflation being caused by MRI directed biopsies, not only at baseline, not only at confirmatory biopsies, but also at subsequent biopsies, because MRI finds that core of the tumor that contains the highest Gleason grade. Now, can we use MRI to identify men who might be progressing based on the imaging phenotype and therefore avoid surveillance biopsies completely? We must remember that changes on imaging can be due to benign or malignant causes. So here's a man on active surveillance. You can see that in 1 year, his peripheral zone completely changes from being bright on T2 sequences to having this dirty peripheral zone. And this is because he has now had a catheter placement. So this is benign. Here's a man who seems to have a mass at the left prostatic apex. You can see that we followed him over time, and this mass seems to disappear. This was just mass-like prostatitis. Here's a man who should be suitable for active surveillance. You can see that over time, you just get more and more dirty peripheral zone over time. And you can see that this is just 3+3 disease that's just increasing over time. But it is still 3+3 disease. On the other hand, this is quite different. You can see in the left peripheral zone, there is a mass that's emerging. In the right peripheral zone is a more diffuse abnormality, a PIRADS 3 abnormality. So you can get multiple features occurring within the prostate gland. And these could be related to malignancy, but could be related to non-malignant causes also. So how good is MRI for determining whether histological upgrading is occurring or not? Well, this systematic analysis has just been published. 15 studies with more than 2,200 patients with an overall grade progression rate of about 27%. So if you took 1,000 men undergoing MRI for active surveillance monitoring, you'd expect between 200 and 300 to develop histological upgrading. Now you'll notice that about 2/3 of these men showed no progression on the MRI, so they seem to have a stable appearance. However, if you were to biopsy these men, 100 of these men would have upgrading which the MRI would not see. So these are false negatives. On the other hand, 1/3 of men would have MRI features that suggested that the patient was progressing. These patients would undergo both a systematic and a targeted biopsies, but only half of these men would actually have histological upgrading. In other words, MRI is not suitable for the monitoring of patients on active surveillance because it is not accurate enough to either rule in or to rule out grade progression. So how should you use MRI? MRI use should be prompted by either clinical, PSA, or other biomarker changes, recognizing these false positive and false negative rates. So in fact, there are a number of cautionary messages about the use of MRI in active surveillance. Using MRI with systematic and targeted biopsies before inclusion into active surveillance definitely reduces the probability of discontinuing AS within the first couple of years. Using MRI with targeted biopsies on patients already on AS increases the cumulative probability of AS discontinuations, and a lot of this is due to Gleason grade reclassifications. But some of this is not progression, but merely a grade migration related to stage migration. Finally, we must also remember that MRI may actually be promoting the loss of confidence in the AS process because it might be increasing biopsies, it seems to be increasing anxieties, and it may in fact be leading to overtreatments. So this speaks to the need to better communicate MRI results. Here, for example, is a man on active surveillance whose PSA in fact goes down over a year, and you can see that the left peripheral zone seems to clear. How did we communicate this? At that time, we use the PIRAD system. More recently, we've started using the precise reporting system. The precise system grades changes on MRI in active surveillance patients on the likelihood of the change representing aggression or not. So if you have a precise score of 2, there is a reduction in the volume or conspicuity of features that were previously suspicious. A precise score of 4 is an increase in the size or conspicuity of features suggesting cancer evolution. But what do the guidelines say we should do? Well, the guidelines are very clear about the role of MRI in active surveillance. It certainly recommends the use of MRI for the selection of patients going onto active surveillance. Indeed, MRI is recommended before a confirmatory biopsy. But you can see that MRI is nowhere during the follow-up of patients on active surveillance. It advises PSA, it advises DRE, but nowhere do you see the role of MRI in the follow-up strategy of active surveillance. So here are my take-home points. MRI increases the precision of patient selections for active surveillance, helping to minimize the inclusion of higher risk patients. Remember that MRI-directed biopsy can result in risk inflation both before and during active surveillance. During the follow-up period, MRI and MRI-directed biopsies should be prompted by changes in clinical factors, PSA, and other biomarkers. Don't rely on the changing imaging phenotype alone to prompt additional histological sampling. And you certainly shouldn't rely on the MRI alone as a trigger for active treatment. Clearly, structured reporting is important, and shared decision making are key for the long-term success of the use of MRI for active surveillance. Thank you very much for listening.